I understand, before we kick off on the main subject, that you have an interest in transference and counter-transference. I mean, it's a vast topic. It's a huge topic. And depending on which school of counselling you work with, depends on exactly what it means. It can mean, it's really honest, it's simplest, it's me being aware of your feelings, you being aware of my feelings, and depending on which way it goes, depends on whether it's transference or counter-transference. But there is also many other ways it can be understood as well. So I guess what issues around transference are you finding that are coming up in your sessions?
The issues that generally come is basically related to the empathy issues.
Right.
Which, being an alcoholic, the other person is an alcoholic, there's some sort of empathy connection.
Absolutely.
That transfers.
Mm-hmm.
And that I notice very frequently in myself. So each time whenever these things happen, I try to say myself, I'm just an instrument.
Right.
Whatever is happening, he needs to take care. Between me and him.
So, are you feeling, because, that dynamic that exists when one of us is in recovery and the other person is entering into recovery,
yes,
or you're helping them, can both be a positive thing.
Yeah.
It can be a major tool because it's within the individual who is new to the process. It creates a feeling of safety and a feeling of, wow, you actually understand what I'm talking about, you've been there before, there is no point in me trying to manipulate you because I quickly identify that you understand that manipulation, so that technique is no longer valid. So in that sense it can be a really positive tool. But in all empathy work, it is so important that you also, whilst immersing yourself in the client's world, you must always keep a foot in your own world. You should never leave your own world entirely. And part of the skill of being a counsellor, and it does take a degree of practice, this, is that you can bring yourself back out. And you can get swallowed up in the client's world if you don't learn that skill. And really that's what's happening. When we spoke yesterday about parents being engulfed in the madness of the addict's son, then what they are doing is they're using their natural parental empathy, and that's great, that's fine, but they are not remembering to keep their foot in their own world, and they're getting sucked entirely into the client's world or their son's world, because obviously it's a family relationship there. Now, okay, that's the family dynamic, but here we're talking about counsellors and we're talking about clients. And boundarying is so important in that world. So, when we talk about boundaries, which is how we reinforce and learn how to use empathy, is by having strict boundary control. There's no point in having boundaries if they're not discussed before you begin, at least your initial session. Everybody's got to know where the boundaries are. You can't just expect someone to know, because you're leaning across, you're saying, I really understand you, you're showing that you understand, you're feeding back through various counselling techniques that you understand, and that not only do you identify, but you're being empathic. So really, what you're doing is offering unconditional love to the client. Unless you've told the client, okay, this is where it stops, this is where you and I, we meet it at this point here. Unless you've gone through that with them, then they're kind of, well, okay, so you're loving me, which is a bit scary because I'm not used to that. How do I love you back? Because they want to mirror what you're doing. So, you know, you must discuss where those boundaries are. And the clearest, simplest boundary is around time. Our session begins here. This is our relationship. Our relationship is within this session. And our relationship outside the session is different. We do therapeutic sessions within the session. We do not do therapeutic things outside of the session. There, we have a different relationship. So, timing is really important. If your session begins at 11 o'clock, it should begin at 11 o'clock. Now, obviously, there are reasons why things run late. But if you've agreed you're going to do a 1 hour session, or in the UK, we have counselling hours, 50-minute session, 10 minutes notes. But we say to the client, that's what that is. And when we reach the end of that, that is the end of it. You will find sometimes that the clients like that love. Because clients, they're very hungry for love. And they will, at the end of the session or within the last 5 minutes, suddenly try and throw in a new topic because they want you to carry on.
Yes.
So, a bit like a puppy. A puppy knows that, okay, you're going now, aren't you? Oh, come on, I'll play this game with you instead. And that's exactly what a client may try and do. And you've got to remember your boundary and say, okay, we decided that's what we were talking about today. That is an issue for another session. And that's a lovely phrase to be able to use. Hear what their issue is and say, oh yeah, I hear your issue. I think I'd like to talk about that in another session. So you're both accepting what they're bringing, but also reinforcing the boundary. And that is really important. So you've got to be structured in what you do. Yes, you're available for your client, however, it is conditional. So although we talk about unconditional love, the periods of time in which we can give that is where we build our limits in. Otherwise, we'd end up being just totally there 24 hours a day for our client, and no counsellor can sort of stand that kind of impact, because otherwise, essentially you've stepped inside their world, you're living their life. That's neither therapeutic to them, but it's quite destructive to you. So when you talk about transference, that's a positive aspect is that I identify, for example, if you're the client, I identify with yourself, and we set up, you know what, there are things about each other that we intuitively understand. But there can be negative aspects of transference as well. So, while simultaneously, as a counsellor, I can use transference to feel your pain, and I physically feel your pain. As the counsellor, I hear what you say, and I sense it inside of me, and I physically feel your pain. But I always have to have a foot in my own world. What I need to be is aware of your pain, but not overwhelmed by it like you are as a client, which is why you come to me. So I need to know when to be aware of the counter-transference or transference is taking place, and that I need to be, once I have awareness, I can do something with it. I can then say, okay, I'm going to pull back a little into my own world. In a counselling session, if you want to demonstrate that to the client, you literally do that, because you've got involved, we've leaned into each other, we're talking closely. Okay, so now this is getting a bit heavy, I need to get my own world back, so I physically move back a little. I take my eye contact away. I sort of make a break in that. So I'm managing, and then I go back to moving in. I'm managing the transference, because I was aware of it. If you're not aware of it, if you've allowed it to happen and you just got wrapped up in the client's world, and you've stopped empathising and you've begun sympathising, because that's what we do. If we're not good at this, we start to sympathise, and that's not helpful to the client, not helpful for you. In fact, it's really quite destructive to you. I did some very interesting research on counsellor burnout through use of empathy. And I looked at that through a psychodynamic research technique with quite a lot of clients. And it was really interesting, the amount of counsellors that I was working with for my research, and who said, no, I don't have burnout, I do this, I do this, I do this. But actually when you looked at the transcripts of what they said, there was lots of but, however. And you could see that that was underpinning their denial, that they were really kind of getting too involved. And you can get too involved in the client. Now that's great to get really involved, really feeling things for 2 or 3 minutes, or for 5 minutes. It's all down to you as an individual, and there's no right or wrong. You really give yourself to that client, and that is very therapeutic, as long as you bring yourself out of it as well, and you demonstrate that. So the client knows, they might not know cognitively, but they know intuitively that, okay, I've given you an awful lot there, and I sense that you're now moving away a little, you're disengaging a bit, just to take a break, and then you're re-engaging. So you're taking the heat, the temperature, out of that counter-transference. Counter-transference is where they're doing it with you, and you're just giving them too much. And yes, okay, so when I'm working with a client who has for years suppressed their emotions to feed in a little of my emotional input into them to help fire up their emotional awareness, that's great, that's a tool I can use. But remember, they don't know how to work with counter-transference, they've not been trained in this. So you really have to be aware, I'm deliberately starting a fire in you. So you use the same techniques of pulling back, of sort of dampening down the fire that you started. But you're trying to raise their emotional awareness. So I will feed into you an emotional event that happened to me. And the reason I'm doing that is I want to kindle your feelings of emotions, because I suspect you've had a similar emotional event. And I want that emotion, your emotions, to raise in you. I don't want you to take on my emotion. The whole point is I'm trying to find your emotions, help you find your emotions. So I'm positively using counter-transference because I'm aware of it. If it's happening because I'm not aware of it, then that's a negative thing, because it's out of control. So that's how we can use transference in that respect. There is also another idea of transference. This is out of control transference or counter-transference, it can go both ways. And that's when it's used in not a counsellor dynamic, but actually it's a bit like displacement, where I actually take the, as a client, I actually take my emotions from or give them to another person in my life. So it's not the counsellor, it's another person in my life. And I overburden them. And people, that can be a real problem in relationships. And I'll speak from personal experience. As prior to actively using, because I always consider myself to be an addict, or at least to have those personality flaws, if you like, that can be found in the DSM around for example, the various disorders, that they stop me from making effective relationships. Being a human being, being an animal that is a human being, we have evolved to live in groups. So we either live in a group, you can consider it to be a herd, or you can consider it to be a pack or a pride. It's got hierarchies in it and things, but the point is we make relationships with other people. And if you have a personality disorder, that fundamentally stops you from being able to make functional relationships. And that is why so many addicts, because they're incredibly, we use the expression that we're incredibly sensitive. Do remember that there is no such thing really as sensitivity. there is very powerful emotions. And usually for addicts, they're around fear, they're around anger, and they prevent us from making functioning relationships. So we isolate, because we're driven into isolation. We don't choose to isolate, we're driven into isolation. And once you move into isolation, you start to have no reference points with other human beings as to what is the common accepted right place to be. The advantage of living in a large group is, within us there is a commonality of what do we accept to be normal. And I know you could discuss forever what is normal, but you know, we do kind of keep recentering ourselves. Just like in science you'll use one clock to centre another clock, so they always agree on time, they synchronise with each other. Human beings need to do something akin to that, and we do it by living in groups, because we evolved to live that way. As soon as we kind of lose that attachment to a group because we can't make functioning relationships, our thought processes begin to become a little different. And we begin to see our normality as being, well, we always think I always think I'm the normal one and I judge you by relation to me. But because I've moved away from the group and I'm not synchronising, I begin to see you as being, you're the ones that are all mad, I'm fine. But I'm getting pushed further away from the group. And at some point I will discover that various substances or behaviours actually suppress my, I'm going to say sensitivity again, but do remember what I really mean is I'm suppressing the impact that those anger and fear emotions are having. So that's quite important. And personality, if we can't make functioning relationships, that's fundamental to our problem. That's the underlying issue, I think, in addiction, which itself can be discussed as to what do we mean by addiction. And that might be an interesting point to pick up now with the group. There's 4 of us here, there's 5 of us here. My mathematical skills have just left me that. What do we think addiction is? Would anyone want to give us a quick definition of what they think addiction is?
What may be disconnected.
Well, in the DSM, addiction is something where you have withdrawal symptoms. Fundamentally, it enters into 1 or 2 other areas, but it says addiction is the medical model. It says it's where you suffer from withdrawal symptoms.
Also, where it affects functionality in 2 or more areas of life. And apart from that, it is also characterized by an obsessive-compulsive pattern, where the individual starts doing things, or they experience what is called as loss of control as well.
Okay, so there's a clear, very scientific definition of addiction. However, somebody else might come to you and say, particularly if they've read the work of Dr. Silksworth in the big book, they'll say to you immediately, oh, addiction is where I have a physical compulsion, and it's a physical compulsion and a mental obsession. I get that the right way around. So they're including another aspect, which you alluded to by saying an obsessive behaviour and things, but they're talking more about not only the obsessive behaviour, but much more of the idea that addiction, as in taking substances, is self-medicating an underlying illness.
Yes.
And there is a whole range of definitions that you can use to say what is addiction. I can't speak for India because I don't know how it works in India, but I can speak for the UK, where there is considerable confusion as to how we should approach addiction. And part of that confusion is that so few of us sit down and say, what do I mean by addiction, before actually saying what I should think we should do about it. We kind of in our own minds think that addiction means the same thing to everybody, and it doesn't. And that is a fundamental problem. So we will talk, Addictions UK, and when I'm working, we work in the field of pathological dependency. So a dependency that is born both of mind and body. That's exactly. Which is reflecting Dr. Silksworth's idea. We will also acknowledge the medical definition that it's something that creates withdrawal symptoms. So, hence why it's pathological. And that's our definition and things. So we always try and say, this is what we mean by this. A bit like the boundary discussion. How can you have boundaries if you haven't told the other person what they are? Well, how can you be talking about addiction if you haven't actually sat down and said, what do we mean by this? Because I could go on for an hour talking about the mental obsession, and the poor doctor says, what's he talking about? I don't recognise that. That's not what people come to me for. They come for me to give me a benzodiazepine to allow them to be withdrawn from alcohol. That's what addiction is in his head, and for me it's something completely different. I do very little work, in fact I do virtually no work, in the medical model because that's not where I'm qualified. My addiction work is all about what are your underlying personality disorders. So, you've got to be clear about that. Okay, the next part of the little talk I got here, the lecture or whatever you want to call it, I did jokingly want to call it, after Jane Austen's work, Sense and Sensibility, I wanted to call it Spirits and Spirituality. And the reason that in my head that was a little joke for me was, in the UK, so often I will say to somebody, okay, we want to look at spirituality, and they'll say, oh, we want to talk to people who have died, because that's spiritualism. And again, when using definitions, don't assume that people know what you're talking about. It's a total aside to this, but it is within my remit. I don't only work with addictions. I always make sure that I work with people presenting in other ways with different issues to keep my work fresh. And this gentleman came to me, and I can't remember what his issue was. I think it was probably anxiety. And he said, I've been referred to you because they've told me I should do some CBT. And I'm terrified. Terrified about CBT. And then he said, and I'm looking in this room that I'm sitting in, and it's so comfortable, it has sofas, and very soft furnishings, and a few antiques and things. He said, where's the machinery? And now I'm starting to think, oh, what's happening here? And it occurred to me that he wasn't too sure what was going to be on, so I thought, okay, let's find out what he thinks is going to be happening. And he said, eventually said, well, CBT, that's where they connect you to the electricity and give you large electric shocks, isn't it? And he was terrified at this idea, and no, that's not what we do. And obviously I had to begin to explain to him what CBT was, how it worked, why we were going to do it, so he had an understanding. And he obviously, first of all, relaxed a great deal, because if you've been referred for anxiety and you think that you're going to have large electrodes attached to your brain and the large electrical currents pass through them, it's clearly not going to do your anxiety any good. And he was a very anxious man, and we have to understand what that meant. And I know I'm maybe sort of teaching my grandmother to suck eggs, as I said yesterday, but really I do reinforce that point time and time again. There is a temptation, because we work in a certain field, to use initials to say, CBT. Well, why don't we say cognitive behavioural therapy, which is that we get used to using that shorthand and we assume the clients know what we mean. And there is a little temptation, maybe, for our own egos to say, I know something about this that you don't know. So I'm building a power dynamic. Now in counselling, in person-centred counselling, we need to eliminate that power dynamic. It's different in psychoanalysis, where people do expect you to know more than they do. But if you're going to be working in a person-centred way, then you need to release that power dynamic. So I dress the same as my clients. I work at my client's level, I respond to them at their level. And that's not being patronising or anything, it's saying, you are the expert about you. You are the one that knows the most about you. What I know about is helping you to release that information and empower you to work.